I'll be doing too much of this if I'm in the middle, so why don't you take it? Do we need a start? Well, no one's telling me not to, so I'm going to go ahead and start. My name's Weil. I'm editor-in-chief of the Journal of Health Affairs, and it's really my pleasure to have this time with our my two co-presenters this afternoon. Along the theme of the power of engagement, which is the theme for the overall Colorado Health Symposium this year, we're going to focus in on engagement that's needed to build a healthier America. The stage is set. I think, unfortunately, the basic facts really are known to anyone here and to the many of you who we know are watching us online. We spend more than any other country in the world. We don't have as good health outcomes. We live sicker. We die younger than many of the other countries in the world. We have tremendous disparities in how we fare as a nation on health and well-being measures. And as has been said, when it comes to matters like life expectancy, your zip code can matter more than your genetic code. In this context, it's time for some new thinking, and some of that new thinking was prompted by the Robert Wood Johnson Foundation, which created a commission to build a healthier America. And they recently released a second report, and the second report called for a seismic shift in how we address health in our communities, our schools, and our workplaces. And my colleagues here were both commission members for that commission. Mark McClellan, who's a senior fellow at the Brookings Institute, was the co-chair of the commission, and so he'll be starting off to describe a little bit about how the commission functioned. Annie Warhover, of course, is the CEO, the president of the Colorado Health Foundation, and she was a member of the commission as well and has a great insight into what it is involved in trying to take the higher level recommendations and apply them to a state that has the goal of being the healthiest state in the nation. So my role is to facilitate the conversation. We are taking questions from the audience on cards as well as online through Twitter. But without any further ado, Mark, why don't you just introduce us to the Commission to Build a Healthier America, what your role was, and give us the highlights of what the Commission found.
Well, thanks, Alan, and thanks to all of you who are here and joining us online as well. The Robert Johnson Foundation's Commission to Build a Healthier America has been a top priority of the foundation. I want to give some special thanks to Risa Lavisa-Mori for her vision and commitment to really making sure that we're doing all we can to focus on improving health in this country. And we had one basic charge, which was to identify effective steps to improve health other than health care. Now, if you were with us this morning, you know that at one level, that's pretty easy. 90% of the determinants of early morbidity and mortality in this country are related to things other than health and other than health care. On the other hand, it's pretty challenging because many of these other things seem hard to move and seem maybe even to some impossible to move. So we spent a lot of time in our initial report focusing on 10 different recommendations, and that report came out in 2008, and it's still available on the web. In our recurrent activities of this past year, we focused in on 3 areas where we thought there was a special opportunity to take steps to help improve the nation's health. The first of these was experiences in early childhood. And I think you've heard today, and I think in many other contexts, about just how important the different influences on children, both at home, in the community, and preschool, can all be on shaping health behaviors and other factors that influence their long-term well-being. Exposures to stresses early in life have tremendous evidence suggesting big long-term impacts on things like occurrence of chronic diseases, as well as health behaviors. Second area where we focused was on opportunities that communities can provide to make healthy choices. And this is one reason we got Ann involved. She's going to talk a little bit more about this in a few minutes, I hope, because there is now a growing body of evidence that the places that you live matter. We talked about the importance of zip code earlier. Around Washington, D.C., where I live, depending on which zip code you're in, just in the metro area, life expectancies differ by 9 years. There are parts of Louisiana, New Orleans, and some of the suburbs where the differences in life expectancy are more than a decade. Even here in Colorado, which I know is overall one of the, if not the healthiest state in the country, here in Keystone in Summit County, that's the 5th healthiest county in the state, with half the premature death rate and half the child poverty rate of Denver County, which ranks 39th among counties in the state. So a lot of variation, and again, where you live is correlated with a lot of behaviors and other things too, but it's also influenced by how safe the environment is, what the opportunities for improving, for following a good diet are, for regular exercise, and other influences on how you live and work and play and spend your time. And then finally, the third area that we wanted to focus on was to break down that dichotomy between healthcare and what it focuses on to improve health and these population health factors that are so important, related to behavior, related to environmental exposures, and things like that, and really try to ask the question of what feasible steps can healthcare organizations take to help improve health overall. I think you mentioned, Alan, that we spend much more on healthcare in the U.S. We don't have significantly better health outcomes. In fact, we've fallen further behind other countries in terms of overall measures of population health, like early birth weight infants and life expectancy. I don't think that should be surprising when you think about the fact that however good your healthcare system is, that's not what's really, it's going to make a tremendous difference in the lives of many individuals with illnesses that can be treated, and more of them can be, and that's tremendous and that's great. But it's not going to make a big difference in moving things like chronic stress exposures and early childhood influences on behavior and how you spend the 99% of your time that you're not interacting with the healthcare system. So finding ways to strengthen those ties seem like a good third area, and in fact in our report we found lots of very promising examples whereby health professionals can take a somewhat broader look at their role and their mission in helping to improve health of their patients by working more with social services, by investing in community health approaches, and that ended up being a very important part of the report as well. So that's an overview of some of the three main areas. My personal interest, just given my day job in health policy, has been around that third recommendation I mentioned, around those ties between health care and truly taking steps to improve population health. Within each of these three major areas, we had some specific recommendations in this area for the connection, improving the connection between health care and health. We focused on adopting new health vital signs that help us assess and understand the non-medical indicators for health, things like employment status and access to healthy foods, educational attainment, chronic stressors. Second area was creating financial support for health professionals and healthcare institutions to address the non-medical factors that can influence health. That, again, may seem like something that's a field from healthcare, but there are many organizations, not just new ones, but old ones, that have been taking steps like helping to address social services issues, having a home, having shelter, having assistance with getting a job, or assistance with nutrition, assistance with dealing with the risk factors for chronic diseases that are making a difference in people's lives. We have a lot of specific examples of those that we talk about in the report. And then finally, incorporating non-medical measures of health into community health needs assessments. One of the issues in the the Affordable Care Act was pushing a bit more on the community health needs that nonprofit organizations in healthcare are supposed to serve. And now there are some good examples around the country of ways in which these healthcare organizations can have a demonstrable impact on improving some of these factors that really influence population health in their community. So that's a summary of some of the things that we did. There's a lot more to it, as Ann knows, but I encourage people who haven't had a chance to take a look at it yet. It's on the web. You can just Google the RWJF or the Commission to Build a Healthier America and get a lot more information that way.
Thank you, Mark, for that introduction. And Annie, let me turn to you. You joined the commission. You talk about your role and what you took out of this process.
Great. Well, first of all, it was really an honor to be part of the commission. I'm not a health professional. Health has been a relatively new career for me, and I learned a lot. I went first as a real learner, but as I got into the commission meetings, I realized that some of the things we're doing at the Colorado Health Foundation were really practical examples of, and if you will, pilot projects to test some of the theories. And I could speak to those during the commission meetings. Another thing you should know about the commission that Mark led was, first of all, it was supported by the Robert Wood Johnson Foundation, and it was full of healthy debate. We didn't all come to the table agreeing. We came from lots of different backgrounds, both political backgrounds, geographic backgrounds, expertise backgrounds, and really had a lot of healthy debate about what these recommendations are. So I think that just underlines really the significance, and to me, one of the most significant things about the recommendations was that Robert Wood Johnson Foundation, the largest health foundation in the country, is emphasizing early childhood experiences, not just early childhood health, but early childhood education, early childhood emotional development, and early childhood health as being critical to the culture of health and to making the nation a healthier population. So that I think is really a critical statement on their part. When we were at the commission, we visited a early childhood learning center in Anacostia, and which is a very low income sector of Washington, D.C. And of course, we were just invigorated and inspired by the work that the teachers and the director of that early learning center was doing with a population of kids that really had no role models at home. Their parents were taking 2, if not 3, bus rides to the nearest grocery store. Violence still existing in the neighborhood. And here these kids came into this relatively protected setting to try to change what they believed about the world. They believed before they came there that the world wasn't a safe place, that it was okay to be hungry, or it was normal to be hungry. They went into their safe world in this incredible early childhood center and learned that things could really be different. And of course, the hope is that they take that back to their families, but we watched them eating lunch in a family-style setting, and really that was the first experience they had with that. This is 3- and 4-year-old kids. Incredible experience. There was a woman on our commission, Rebecca Olney, who runs an organization called Health Leads. And to Mark's point about bringing really more health into the community, what Rebecca teaches health practices to do is to write prescriptions for healthy food, to write prescriptions for fitness, to partner for medical practices, to partner with the local YMCAs. And so that when they talk to their patient about the necessity of physical fitness, they don't just leave them hanging with, okay, well, what do I do about that? They can actually take out their prescription pad and write a prescription for the YMCA, get them into that facility, and be able to make that accessible to them. You know, accessibility is huge. Somebody this morning talked about, I think it was Lori Dorfman, talked about the walk around the lake. which she took this morning. That was her choice to do that. That was personal responsibility. But if the lake wasn't there, she wouldn't have been able to do that. And who put the lake there? You know, that was a private investment by Keystone. And it was probably because there was some demand. But we need all sectors to be involved. It was the perfect example, I thought, of the balance of institutional accountability and personal responsibility. So you've got the person making the choice, but if you don't have access, if these kids don't have access to healthy food, if their neighborhood isn't safe to walk around in, how can we just continue to keep educating them to do that? That seems like a waste of energy to me. We've got to make the things available for them. So the early childhood was critical. Where the Colorado Health Foundation has invested most of our resources among these three areas is in building healthy communities. And we do believe that that is the single most important intervention to combating the factors that work against somebody's health. So creating environments that make the healthy choice the easy choice, making it accessible. We have an initiative called Healthy Places, which has invested resources in 3 communities in Colorado, a neighborhood of Denver, a suburb, and a rural area, Lamar, Colorado, which, by the way, is the unhealthiest place in the state, to put in what those communities believe are necessary infrastructure improvements, programming improvements to make their communities healthier. It is transformational. It is really exciting to see how when the environment changes or when people feel like they have control over what their environment can be, how excited they get about the prospects of health. Lamar, for example, has decided to use health as their economic development strategy. So here they are in the Eastern Plains, going the way of many rural towns in America. But now, because they're going to be a healthier place, they're going to use that as their viability strategy for the future. It's also made them believe that if they can change how they feel about health, maybe they can change how they feel about education as well and start working on their education system and other systems that are critical to a healthy population. So we're thrilled that there's another foundation, Robert Wood Johnson Foundation, working on the culture of health. We at the Colorado Health Foundation hope that not just foundations, but business, government will join in this effort. And it will be that, just like we have a culture of education in this country, why can't we also have a culture of health?
Well, those are great introductions, and I want to focus the first portion of our conversation on what I think is the biggest challenge when you bring a bunch of smart, dedicated people together and you write this great report, and it used to sit on the shelf, now it sits on the internet. And the question is, how do we go from there? And the two of you each have very unique and important perches from which you can observe but also affect whether or not the recommendations in this report go into effect. So I'm going to ask a few questions of each of you in turn, really focused on this question of taking the next step. And Mark, I'm going to start with you. To those in the room, we're covering ground that has some relationship to this morning, but I want to take it the next level. You, as you said, are out there every day working with health systems that are in the process of rethinking and re-engineering, figuring out their future. They're metabolizing a lot of changes, the Affordable Care Act payment changes, accountable care, and in you walk with this other thing, which says, by the way, you might want to get interested in early childhood education. You might want to build linkages to social systems. What kind of a reaction do you get when you raise that issue?
Yeah, there are different kinds of reactions. Like, one you might guess is, oh my gosh, we're already busy just trying to keep our costs down in the short term and trying to keep our patients who are likely to show up at the emergency room tomorrow out of the emergency room. And you're asking us to take a step back and think about these. Yes, we agree there's a big long-term determinants of health, but we're dealing with the here and now. And there are a couple of strategies that have worked. One is a recognition that even if you're focusing on some short-term health issues, very often the most effective step to take to address them is not something that you can do within your traditional healthcare delivery organization, within your office. So you mentioned health leads, and that's a really good example. Many of the so-called frequent flyers to emergency rooms are there because they don't have a home, or they're because they are not getting good nutrition, or they are not in a job and not getting support outside of the healthcare system. And so spending some time and effort connecting those individuals, this is not everybody who comes through the doors, but just as healthcare organizations are getting better at targeting the right patients to go to the cardiologist, or to go to the endocrinologist, or perhaps to be admitted to the hospital, they also can develop better predictive models and better targeting capabilities for these kinds of social services and social supports. In fact, for some patients with chronic diseases or with high risks of acute healthcare problems, there's some pretty straightforward steps that can be implemented. North Carolina, Arkansas, other states that are not yet way down the road in some ways on reforming their healthcare systems have started programs for nurse practitioners or social workers to work with families who have kids with asthma, for example, to help address risk factors in the home, which might be lack of air conditioning or carpeting problem or a pet issue or something like that. You don't do it for everybody. It's not traditional healthcare, but for those individuals, it can be the best way to have an impact on some very significant health risks and health costs in the short term. Same for better programs around prenatal care and perinatal care. There are several programs in Washington, D.C. that have done a lot to get down the risks of low birth weight infants by taking some social service, family support type interventions to the home. And those early childhood education programs have had some success in at-risk families and helping families develop better practices for their kids at home. A lot of those prenatal programs, a lot of those early childhood programs have initiatives that are targeted to the parents just as much as to the kids that Annie talked about. So those are specific steps that healthcare organizations can take now. For the longer term, it does take some help to make sure that this focus on improving long-term health does get reflected in the priorities of and funding for healthcare organizations. So it's not a problem to encourage physicians and others to recognize that steps taken now, like keeping kids in school or getting into preschool, is going to have a big impact on their health, can help reduce their smoking risk and improve their life expectancy. It is hard for them to find time in their day to focus on those issues when they're getting paid for other things and there's no financial support for it. There are a number of community initiatives that in some cases have been led by the state with their Medicaid program, in some cases have been a regional collaboration that have started to put some tracking and funding behind measures of these longer-term indicators of these longer-term outcomes. So, for example, the state of Maryland now has as one of their measures for quality of care for pediatricians the rate of preparedness for 5-year-olds entering kindergarten. So it's not something that a pediatrician can handle by themselves, but it is a good thing for people to be thinking about and for potentially tying into some of the payment reforms that we've talked about earlier today. A lot of the so-called accountable care payment reforms or bundled payments and things like that have payments that are tied not just to how many services you get today, but payments that are tied to some measure of quality. And a lot of those quality measures are things like whether or not your blood pressure is under control, whether or not your lipids are under control. Adding to that measures like whether or not you're ready for kindergarten if you're a 5-year-old, or whether or not a patient's other key needs, health needs, are being addressed, is an important way to improve that focus too.
Let me follow up. That was a very, very helpful, and it gives us some reality to what happens when you try to take these recommendations and do something with them. There's been reporting recently that some of particularly the value payment models could potentially disadvantage safety net institutions. Basically, if you're a suburban hospital and you now have to pay attention to kids being ready for school, you make some marginal investment. If you're in a really disadvantaged community and you're now being held accountable for that, or readmissions and all of those other sorts of things, you have a much heavier lift. But you also have, as we talked about this morning, maybe mission alignment. It's something you've been paying attention to for a long time because that's the population you've been serving. So I just wonder if you could give us a little insight, because you interact with such a variety of institutions, in whether you see differences in how they respond to this. Are some just, as you said, do they throw up their hands and they're overwhelmed? Do they embrace it? And are there differences in that based on whether they feel they're in a relatively resource community or in a really resource poor?
It's a really good question, and I think it's like most difficult questions, one where there isn't a simple and quick answer, but that's okay. For many of the communities or organizations that are trying to take this on, they're starting gradually. They're starting by just seeing where they are. In more cases than you might imagine, a lot of healthcare organizations just can't get good comprehensive data on their patient outcomes. That's information that is over in the school system, or is in the public health department, or is in some other insurance plan or doctor's office. So just taking some steps to try to put that information together and share it is a good way to build trust, as well as to identify where the best opportunities are in that community to do something about a health problem. And some of the examples that we've seen around the country, for example, an effort underway at a more community-oriented, low-income provider serving low-income neighborhoods in Kentucky are really focusing on smoking, a very high smoking rate. In Utah, some of the efforts are focused in other areas because the smoking rate is 10%. So there's just a way that you can just start by building data before taking any steps based on changing payments about this. And then when it comes to addressing resources, there are a couple of steps that I think matter. One is, first of all, trying to combine payment streams where you can. So having the efforts going into social services coordinated with the efforts going into medical care, especially for these lower income communities, can really help. In New Jersey, Jeff Benner started a hotspotting program with financial support from hospitals in the Camden area for expanding social services, because he was able to show that, using this kind of data, that a relatively small number of uninsured patients with difficult social situations were accounting for a huge part of the uncompensated emergency room and inpatient costs for the hospital. So it was a win-win for everybody, for the healthcare funding stream to be combined with the social service funding stream. And the first investments they made were not in more doctors, more primary care physicians, more nurse practitioners, but in more social workers to help support and connect those individuals with programs. And then finally, even if you are tying results to outcomes and not just combining funding streams, there is this debate about whether or not you should account for the lower, more challenging circumstances in many of these communities, or if you should focus on improvement. And the people who support improvement tend to highlight, well, look, we're starting out at a low place here, we need to account for that, and what we really care about is bringing these groups up. So tying resources and payment reform to improvement, even if it's at a low level, is still a step forward. The criticism of that approach from the other side is, well, then aren't you sort of tolerating this lower level of performance, and won't this mean we're really never going to get rid of these big inequities in important health outcomes? And I think that's it's a tension that people need to recognize. My personal view is that it's important for some of these initiatives to focus on improvement, but at the same time, that doesn't mean you're taking your eye off the ball of absolute performance levels. That's the point of those improvement programs, is to get to a reduction in those disparities in health.
Great.
Alan, can I say something about that?
No.
There's also the other way of looking at it, and trying to incorporate health into other systems.
Yeah.
So, for example, housing. Great example in Denver is the Denver Housing Authority, who said, we build housing for low-income folks. We also care about their health. We also care about their education. But let's build this housing project around health. and see if we can actually improve health outcomes through the design of the project. And it's called Mariposa, and it's just remarkable what they've been able to incorporate into the development. And then they have the programming that Mark was referring to, the hotspotting program. They've been able to reduce emergency room visits by a wide margin just by helping their residents understand why you go to the emergency room, why you get picked up by an ambulance, and why you can maybe get your temperature taken in a different way or treated for a cold in a different way. So they've been able to impact it both ways. We've also seen health incorporated into transportation advocacy and transportation systems. How does health become a planning component of a metro-wide transportation system? I think that's another great example. Education. The Colorado Education Initiative in Colorado has a whole stream around keeping kids in school healthy. But they're primarily about education reform and making sure that our schools can implement education reform, but they recognize that, you know, doing that alone without paying attention to kids' health is not going to be as effective. And so they've incorporated health into their work as well. So it's both the health providers and insurers looking at it, but it's also everybody else in the community saying health should be integrated into our work.
And I should just add, if you're interested in these issues, you're not lucky enough to live in Colorado with Ann. And there are a lot of good reasons to live in Colorado, I keep finding. But,
I'm one of them.
Right, that's right. But if you're not that lucky, these kinds of programs are being replicated nationally. And the Federal Reserve actually has
Yes.
a lot of support programs that provide help through all of its branch offices, all of its member banks around the country. So you may not have Ann close by, but you've got the Federal Reserve, and that's a good place to go for local resources on financial investments in transportation, housing, and so forth that can be tied more effectively to thinking about and improving population health.
And funny, one of the reserve banks is in Denver. So Annie, you jumped over, it's quite all right, but I want to pull back a little bit to lead into the example you gave. And just and step back a little bit with me. I mean, the philanthropic literature is littered with examples of particularly national foundations having an agenda to change local outcomes and failing miserably. Now, you're state, you're not national, but you have a very local focus. What did you learn from those? How do you avoid some of the pitfalls of being the big player and coming across as telling a locality what to do? Start us back a little bit before we get to those examples.
Great. Well, that is a challenge, I think, for foundations, period. You know, we hire experts at the Colorado Health Foundation. They're not just experts in health. We've got an architect on our staff. We've got public health. We've got medical practice. We've got education. So we feel like we do have a range of expertise, and yet we also hold this other belief that communities, it goes back to those charts this morning about buy-in versus ownership, and about humility and arrogance, and how do you balance all those tensions? So yes, we've got some expertise. We do a lot of research. We pay consultants to tell us what the right thing to do is or to give us their opinions. But we also have to balance that with the community. So the example on Healthy Places, I think, is a good one. We hired the Urban Land Institute, which is a nonprofit, but its membership is for-profit developers, architects, financiers of real estate projects. We hired Urban Land Institute to put together a panel of experts in their profession to go to communities that we picked and interview the residents, interview the superintendent of schools, interview the business people, find out what would resonate the most in terms of health, and come up with a series of recommendations at the end of that. That did two things. The recommendations were directly driven by the community themselves, and we got the Urban Land Institute, all these private sector people, really interested in building healthy places. They have now made Healthy Places their #1 priority for their international organization as their responsibility for real estate development, that it should be centered around health. So we got a twofer on that one. But the best example I've ever heard around foundation investment that has backfired, and then being able to go in and redo it. And I won't name names, but an eastern community in Colorado, several years ago, a foundation invested in a bike trail that led from some of the residential areas into what you might call their main street, and no one was riding their bikes on the trail. And the question was, gosh, we invested all this money, why aren't you riding bikes? Well, in that particular community, if you rode a bike, you were too poor to own a car. And it was a stigma to be seen riding a bicycle. And that was before the bike craze, but it was a stigma. So they didn't, there was no understanding of that before this bike path was created. So going into a community and being able to say, what is it that resonates with you, that will help you, is really a key factor. Community engagement. And I'd say one other issue about community engagement. Not everybody knows how to do it. It's a skill. It's it is something that is that some people go to school in. It's developed. It has to be done in a very engaging, sensitive way to the community themselves, or else it will, even the community engagement process will come out as somewhat ivory tower or arrogance.
The example you gave of engaging the Urban Land Institute, a strong national organization with strong developers and architects as its base, it's a very compelling example. When I think of the community engagement you're looking for, you're also looking to engage with a lot of very poorly resourced community-based organizations, social service agencies, direct service providers that are not part of that. And I'm thinking about this humility continuum that we were talking about earlier today. How do you come in to, and you're thankfully one of the largest state-based foundations in the country, you come in with a lot of resources. Their world is very different. How do you build a partnership?
Well, it has to start with trust. It has to start with this continual reinforcement of the idea that there's a mutual relationship here. One of the things we talk a lot about at the Colorado Health Foundation is we're stewards of public money. This isn't our money. This is money that really belongs to the citizens of Colorado. But we can't make it work for the citizens of Colorado. We're reliant on those underfunded social service agencies, those education institutions, the safety nets in all communities across Colorado to help us show our accountability. So it's a very mutual relationship that we continue to try to reinforce over and over and over again through personal relationships, just the way you would do it. I wish people thought of it more like they think about a business transaction. That we're in the business of transformational change, particularly around health, and we need people to help us do that. And we've got resources to pay them to do that. They've got the expertise, they've got the staff, they've got the passion to implement.
Annie, you referred to some disagreements on the commission, healthy debate. One of the touch points that came up earlier this morning was about the framing between sort of personal responsibility and communal responsibility for the environment for people to make good choices. It's hard to imagine a discussion of the kinds of interventions that you all talked about as a commission without that tension point coming up. One person asked, how did you handle your disagreements? I'm going to ask a variant on that theme, which is in particular with that very politically charged topic. How did you all think about it? Maybe the two of you thought about it differently. How was it discussed in the commission?
I would just say from a commissioner, and then Mark had the hard job because he was chair. But I thought we set up ground rules at the beginning. We had it was obviously very respectful debate. But I think we all recognize that there isn't a clear-cut answer to these questions, And if we can put everybody's best thinking into the pot and stir it up, we're probably going to come out with the best answer. And I really think there was that kind of mentality. But there were things that were brought up that we felt, that I think some of us felt like were not within our scope of being able to change those things. Because, you know, you can go really deep into this work and try to change, you know, our whole government system to avoid poverty, for example, or to avoid the incredible gap between the rich and the poor. We weren't going to go there. That was out of the scope. But, you know, I just wish that that kind of debate could occur more often with our elected officials, because I think we'd have better answers. But of course, there's lots of reasons for that not happening.
Yeah, I think it's easier that we weren't up for election.
No,
and,
exactly.
We did have people, Republicans, Democrats, very different perspectives, as Annie emphasized earlier, but they all came to this with a spirit of trying to find some common ground. Which is not to say that there weren't differences in views about roles of individual responsibility versus roles of federal, state, and local governments, differences in views about how extensively the government could intervene, differences in views about the concerns about, for example, growth in state spending and federal deficits and the like. Absolutely, that was all there. But behind the recommendations was some common ground on all of these issues. So if you want to do something about the behavioral determinants of health, which is 50% of the premature death and disability in this country, there is going to be a role for individual responsibility. I mean, that's all there is to it. Conversely, if you want to do something about the environmental, the early life stressors, as you said, the ease of making healthy choices, there is going to be a role for government as well. And the recommendations reflected where we could get to some common ground on each of these issues, and it turned out to be a pretty significant amount of common ground. Regardless of party, there is absolute agreement that we as a society and acting through our governments needed to put a higher emphasis on early childhood education programs. There are differences in views about how exactly that should be funded and what the content of those programs might exactly be, but strong support for even some specific models for funding it based on building in more local support. There's some examples of local taxes that have been raised or dedicated bonds, as well as tying the payments for these programs into some meaningful outcome measures, so we can be confident. You can't measure lifetime health in the short term, but there are some good predictors of how well an early childhood education program is doing. So there's agreement on putting more emphasis on those performance measures in these programs as well. So that's just one example, but I think all of our discussions followed that spirit, and fortunately it made the life of a co-chair not too difficult.
You know, the other advantage that we had is we had a lot of data. Sometimes data brings people together because it's hard to argue with, and it wasn't rhetoric, it was hardcore data about cost-effective programs.
Each of you have raised some examples of programs that you're proud of. Right next to the stack of all the failed national efforts to transform local circumstances is a stack of demonstrations that are funded and occur and arise and have good stories to tell, but there's no replication, no spread. And often, one of the things Don Berwick often talked about is that we should even maybe stop thinking of replication as a term, because what you really have to do is reinvent in every setting, but you don't want to start from scratch. How much attention did you all give to, and what thoughts do you have even beyond the commission to taking these good ideas and making sure that they're available to more than the people in the places that you described?
Well, I think a lot of that is happening now. So the Commission didn't stop its activities when we issued the report months ago. There have been some continued efforts supported by the Robert Wood Johnson Foundation and the commission members to help highlight opportunities to implement these different kinds of reforms around the country. One of the things that was very important to me in taking on this job and then taking it on again as co-chair was the foundation's firm commitment to put their money where their priorities are in terms of supporting new initiatives. I do think it is a challenge, and Annie mentioned this earlier, that this is not just like, okay, here, do these 5 things and boom, you've got a transformed community for improving health. There are so many community-specific factors and factors with the healthcare system, leadership opportunities or lack thereof. I mean, there are so many factors. You just can't do this off the shelf. And so I think it is going to be a continued effort, as you mentioned, to look at what has been learned from successful implementation efforts, try to find some generalizable principles from those, and I think we have some in all of these areas. We've talked about some of them already today. There are more, and to keep moving forward with that.
You know, I think you have to have one of 3 things, or 2 of 3 things, or all 3 of these things. You know, you've got to change an environment, you've got to change systems, or you've got to change policy to make something really sustainable. And a lot of times that does work better if you can get the private sector involved, because they're obviously going to be able to take things to scale at a much greater rate than charitable contributions or even underfunded nonprofits working in communities. So I think that scalability, they're still going to be responsive to local interests because they got to sell their product. But they're going to incorporate that health into it. So I think that's certainly one way. The other way to look at it is to get some national nonprofits involved that can do work all over the country. One that I just call out is the Trust for Public Land. I used to think of the Trust for Public Land as buying big ranches and conserving them so that we could all hike and appreciate the beauty of the mountains. But the Trust for Public Land has a very strong urban park initiative where they're building parks in urban areas all over the country, so that because if you live within 10 minutes of a park, there is a 50% greater chance that you will exercise at the rate that you're supposed to exercise. Now that's a pretty good statistic. What if we could get everybody to live within 10, and that's one of their goals, within a 10-minute walk of a park? We're going to increase the fitness level of America by doing that. So those projects can be replicable and still sensitive to the community.
One of our audience members notes that the Affordable Care Act included a prevention trust fund that has, as I recall, been steadily rated for other purposes.
Where is that, anyway?
Just to, the questioner asked sort of what's happening with it, but I guess I would even go a step further and say, if this is what happens when we pass national legislation that says we're going to focus upstream, what are the prospects for the kind of earlier investment that seems necessary for achieving the commission goals?
Well, I think the Prevention Trust Fund, the Supporter Center, Harkin, and others, a very well-meaning goal. They wanted more money put into initiatives that would improve health, but I think it just goes to show that probably the best way to think about a culture of health is getting these health considerations built into existing infrastructure programs. You can't do better community health as an add-on. It's got to be built into housing programs, land programs, park planning programs, nutrition programs, school programs. And that doesn't say that all of these agencies and entities and commissions that are very busy with thinking about lots of other priorities need to drop everything and focus on health. But I do think it's more about building in considerations of the steps that each of these parts of each of these contributors to our community can take for health. I think one of the challenges of thinking this can be done just with a separate individual fund, and maybe that's what made it an easy target for pulling the funds elsewhere, is that you just think about like even a few $1 billion for prevention is not going to transform the United States population health. On the other hand, making these kinds of changes that we've been talking about in all of the existing programs that have such a big impact on our neighborhoods, our communities, and our lives could do it.
You know, we're in the midst of this big accountability movement in healthcare. Accountable care organizations, instead of paying fee-for-service, we're going to pay a bundle, but you're only going to get it or get the savings if you demonstrate results. The more players you engage, and you've suggested, and the Commission suggests that we need to engage all of these folks, it's one thing to say we're all going to adopt the goals and we're all going to think about health as part of what we do, and that all sounds very positive. But how do you think about and structure accountability when you've got a health entity, a housing entity, an educational entity, and the like, all trying to improve the health status of a population? Is there a model of shared accountability across these kinds of systems?
I don't know if this isn't really shared accountability, but let me go back to that Denver housing example. They're doing a health impact assessment before and after. So let's see if these interventions, programming as well as infrastructure, actually work. Will they have a healthier population? Does the population of that project, that development, get healthier year after year after year? And by doing that health impact assessment, there'll be some indicator of that. The other thing that we have to be really careful about, I mean, we have to believe that health is a good thing to aspire to, and that we have to try different ways to get people to be healthier. Yes, measurement is really important, accountability is really important, but you gotta have the fundamental belief that this is good for society, that this is good for productivity, that this is good for our economy, this is good for education. A healthier population is going to be a better, all around better population for the country, and not obsess too much on the accountability.
And hopefully in the process of doing that, we will figure out better ways to do it and figure out better ways to show what is actually effective. It is challenging work, no question about it. And I've seen approaches that try to build this into just a single organization, say a healthcare organization. I mentioned the example of pediatricians, thinking about and maybe being accountable for and having some funding streams tied to preschool participation and school readiness. So that's just within one organization. There are now community level efforts to have a more community-focused approach to improving health. So it's happening in Minnesota, Oregon. It is harder. There are more entities to align and a lot of different business models at stake, but with the right community leadership, I think those have potential as well. And then, as Annie mentioned, within organizations, if they've just got something that they're focusing on, like a health assessment as part of their overall work, that too can be a step in the right direction. So I do think we're going to get better. You're right, we can't measure everything. I do think we're on a path to getting better measures, and I do think it helps to have short-term measurable things that are good, valid predictors of these long-term health goals. I think that's one of the biggest challenges here is that the problem just seems too big. Oh, how can what we do now affect this child's behavior 20 years from now? Well, it turns out that it can, and I think the more that we can make that clear, the easier it will be to support these community efforts.
What both of you are describing is the importance of building a foundation. You have a North Star of improvement, but it's about building relationships, building data, building intermediate wins, and that if we get caught up in the second and third order questions of evaluation and performance accountability, we might actually impede the work that we're doing now, but we should know that further down on the path we would want to get there.
I have an analogy, and I don't know if people will buy this or not, but I think we did a pretty good job of building a country around the car and our need to be mobile and our need to be able to drive a personal vehicle across the country. And probably at the time, building a highway system like we have today was a monster task. How did we ever think we would be able to do that? But we got parking lots for every car in the country. We got highways, we got multi-highways, what if you applied that same kind of thought process to health? And we started building our country with health at the center of it rather than the car at the center of it. And we could have something that looks different than it looks today. And maybe other forms of transportation would become more the norm because you put something, it's your North Star. You put something else as the North Star. But we were very successful at putting, and I have nothing against cars, I've got one. But we did put the car as our North Star, and we built a very successful road system around that. There isn't any place in this country you can't drive. So I would use that as
Well,
my
lesson number
analogy.
one is it's the interstate system was funded as a defense project. It was to help us with defense preparedness. So we need to tie this somehow
See,
to
I didn't
our
know that.
many opportunities
Productivity.
here. We're running out of time. I want to get two questions in before we have to stop, and then maybe we can tweet the rest of our answers. But a number of people have asked about various angles on mental health, and it feels like we always say it's critical, it's important, it's a part, it needs to be a part, and then we move on and talk about housing and other and parks and the like, which are I don't mean to diminish their importance, but this feels like an area that as a country we've begun to really come to an understanding of how poor our performance is, how great the needs are. Did the Commission have anything to say to help us specifically in this area?
This was actually a major area of focus and continues to be a major area of focus for reforms in that third big recommendation area of expanding the focus of healthcare from just acute medical. Now, mental health is part of health. It's part of it's the key element of the WHO definition, and I think any healthcare provider, any clinician would tell you that, yeah, if you're not working on mental health, you're not serving your patient well. But the fact is we've had very fragmented systems for dealing with behavioral health issues and haven't done a great job under our traditional fee-for-service payment systems of supporting efforts that could help people with mental illnesses get better overall health and avoid costly complications. People with schizophrenia have very high rates of smoking, for example. Some of the highest use, the association of a serious behavioral health issue with a medical condition like heart disease or diabetes or liver disease has a huge impact on frequency of utilization and expected costs in the healthcare system. So we know all that. It's just been hard to do something about it. Some of the reforms that are being implemented by Medicaid programs around the country are doing more to combine funding streams, not just for the behavioral services funded by Medicaid, but for other state and local programs to provide assistance, housing assistance, other local community support for people with behavioral health needs. Denver Health does that. The Hennepin County reforms in Minnesota, Medicaid are doing that, and they're actually tracking for patients with behavioral health issues whether or not they're actually achieving improvements in health outcomes, and that's part of the payment systems in some of these reforms around the country. I do want to flag that there is a special sensitivity around mental health and around sharing data on mental health conditions, and a lot of the efforts to try to improve care for people with mental illnesses involve sharing data, say between a physician and a housing or social worker, so that this needs to be approached carefully in a way that pays a lot of respect to individual preferences and confidentiality. But again, there are some good models now of doing a better job of integrating behavioral health and behavioral issues into overall efforts to improve the healthcare system and health.
Well, let me close with a simple question with a hard answer. A lot of what you talked about was engaging other sectors to help with a health agenda, and I think that's it. And it's nice to hear the receptivity of many of those in the broader community to adopt this as a goal. you're sitting here with an audience that's primarily in the health sector. Now, there are lots of different parts of it, but if you could offer them not just one thing to think about, not just one report to read, but one thing to do differently as a result of the work of the commission and the additional work you all have done on your own, what advice or what action would you suggest people in this room who are in the health sector do to advance an agenda consistent with a culture of health and more specifically the goals of the commission?
I would say be an advocate in your city, in your county, for building a healthier community. And by that I mean talk to your planning department, your planning commission, your mayor, and try to build a grassroots effort for building really a healthier community, and that becomes part of the agenda, because I think that can bring a lot of people to the table. A lot of people are interested in that, and health is not a partisan issue. We find that lots of people are interested in it when you can make it relate specifically to where they live. This whole zip code notion is a really good one.
Yeah, I think that's a great idea. It applies to people who are outside of the health field as well as those who are in it. There is something in your community in terms of a housing or a development program or other kind of initiative where paying attention to health, maybe you can't measure it perfectly, but you can get it on the agenda. That's a great step for those of you who are in healthcare. There is almost certainly something that could be done within your organization that would make a difference on population health. The specific opportunities in terms of a new approach to help low-income individuals get connected with the supports they need, like through health leads, in order to prevent them having health complications, or tying into programs that work on early childhood issues or behavioral issues. There is something out there. So think about a population health focus. Wherever you are, there are some steps that you can take to help improve it.
Well, I think we can all appreciate the contribution these two folks made to the Commission to Build a Healthier America, but also I hope you'll join me in recognizing that through this conversation we don't just learn about what the goals are, but we also learn how to achieve them. A very great insight and engagement with the two of you in not just having a North Star, but also taking the steps towards it. Thank you very much for the conversation.
Thank you.
Thank you.
I am a state senator representing Denver's District 32, and I am also a primary care internal medicine doctor. In my work as a state senator, I serve as the chair of the Senate Committee on Health and Human Services, and there's frequently discussion around what can be done to help us control our health care costs. So I thought, looking at how do we engage people in this discussion of health as opposed to sickness care, and get them to be part of the conversation, since ultimately most of the power is in their hands. One of the ways in which we need to put a lot more thought into is how do we get people to engage in physical activity. So certainly when I speak with patients, I talk with them about the need to exercise, and I emphasize that sometimes people think exercise and they think you're lifting weights or you're on some fancy machine. And I emphasize that if all you do at home is sit around, exercising is taking a walk for 30 minutes. One of the social determinants of health is education and income and poverty and environment. And I was at a meeting last night about the Globeville-Swansea-Elyria neighborhood and a health impact assessment that had been done on them. And I think we forget how important the fact that there aren't sidewalks, the fact that there aren't parks, the fact that the lighting is not good enough for people to feel safe going out at night, and the impacts those have on people living in poverty. I think there's a lot of discussion about we need people in poverty to take more, responsibility for their physical health, and we don't realize the systemic environmental things that exist that make that harder for them. in the past 2 years, I think this awareness has even come to me more as a physician in terms of prevention, spending more time talking to people about the concept of physical activity and really making it as non-threatening as possible.
I am chair of the Health, Insurance, and Environment Committee at the House, and I've been on that committee for several years and been chair for 2 years. Very interested in learning more about what we can do at the legislative level to help improve the health situation. I've been working also in the area of mental health and involuntary commitment specifically. And we have a large stakeholder group that's been working on this issue. And I think it's been really productive to have people who've been through involuntary commitments talking with the providers who put them there. I think just engaging in that kind of discussion changes behavior, both of those who are involved as providers and also those who are involved who may experience the system. So I think one of the things that we do in the legislative process is we try to engage a lot of stakeholders, and I think that often results in people learning a lot more about what other people think. So, and that's one of the benefits, I think, of the symposium is that you bring together people from lots of different pieces of the healthcare industry, if you will, and then we can hear each other's perspectives, which I think is important.